All right, we're going to talk about head trauma. All right, so trauma to the head. We're going to talk a little bit about anatomy, physiology here. Not too much physiology, more anatomy. That's probably going to be the most important part. So head injuries can be life-threatening, obviously, because that's where our brain is. All right, along with that, it can lead to permanent disability if we have any problems with our noodle. The patient's mental status can make assessment difficult. So if they're altered, it may be more difficult to get a definitive, like, hey, what is wrong with you, or what happened to you. So determining an MOI may be difficult, and we may have to use context clues of the scene to figure out what happened and what went down. So when we talk about the skull, okay, we talk about the cranium, the face, the basilar skull, okay, is the weakest portion. And I'm sure we're going to get to it in the slides, but how do we know, or how do we have a very good indication that somebody has a basilar skull fracture? Battle signs. Nailed it. All right, so this kind of is a breakdown of the skull. Again, I said this early in the last lecture. If you are unsure of what the bone is, if you're like, okay, I have a good idea of what the bones are, maybe I get confused about the parietal versus the occipital, just say location, the top of the skull, the back of the top of the patient's head, the back of the patient's head. Okay, just give reference points to where the injury is. All right, you have the maxilla and mandible. Those are important to know. The brain. So the brain is cushioned by what we call CSF, cerebral spinal fluid. All right. If I see a patient that is bleeding from the ears or nose, I might want to take a 2x2 and scoop up a little bit of that blood. Why would I do that? Okay, yeah, what's that test called? Do you remember the name of that test? The test is called the halo test. The halo test. So when you take like a 2x2 or 4x4 and you get a little bit of that blood, let's see, it's leaking from the ears, you set it to the side, the CSF will separate from the blood, and it will ring the blood, and it's very it's like lubricant, okay? That you may get like on you guys ever hunt or anything? Like you put lubricant on your weapons, all right, like CLP and stuff like that. It has that consistency, but it's yellow in nature. So the halo test, we'll see it separate from the blood, and it makes a little yellow ring that looks like a halo. All right, so then we have the meninges. When we're still talking about the brain, these are layers that surround the brain. So when we talk about meningitis, you guys ever heard of that term before? All right, here we're talking about trauma, but meningitis is an inflammation or infection of the meninges. These are the layers that surround the brain. So the outermost layer is called the dura mater. Then you have the arachnoid, okay, and then you have that which is in contact with the brain, the pia mater. So you can differentiate what types of brain bleeds they have based on their signs and symptoms. But most definitively, we need an MRI for this. All right. Don't get too deep into that. When you go to paramedic school, you'll learn all about it. All right. So here we're talking about the bleeding that occurs between the dura mater and the skull. It's called epidural. Epi meaning what? Above. Okay. Epidural. Above. So it's between the dura mater and the skull. So the dura mater is a part of the meninges. It's layers of the brain. So this is between your skull and between the outermost portion of your brain. Subdural, okay, below dural occurs between the dura, beneath the dura, and it's typically venous in nature, okay, so it's probably a slower bleed. Bleeding that occurs between the arachnoid and membrane and the surface of the brain is called subarachnoid, okay, so like I said, more definitively, we need an MRI to say exactly where these bleeds are coming from, but this is just an idea to give you, like epi meaning above, sub meaning below, so you can kind of figure out for yourselves where the bleeding is occurring. And here's just an example of the meninges in the brain, just kind of a breakdown. You have the dura mater. We said that's the most outer layer, the arachnoid, the middle, and then pia is the furthest down. The cranium being the skull, okay? And so bleeding in between the cranium and the dura is called what? Between the skull and the dura mater? Epidural. Above the dura mater. Epidural. Below that would be called subdural. Got it. All right, so the brain is divided into two hemispheres. Okay, each hemisphere has 4 lobes, and those lobes have different responsibilities for us. What makes us us? The cerebellum has it's involved with motion, movement, and coordination. Quick question: if I have severe brain bleed on the right side of my brain, what part of my body is going to be affected? The left side. Okay, it's opposite. All right, the brain stem. It makes up the pons, midbrain, and the medulla oblongata. So, what does the medulla oblongata control? It's up there. Cardiac, respiratory, vasomotor function. All right, so if there's damage to the medulla oblongata, we're probably going to have a patient that is having maybe irregular breathing patterns. Maybe they have narrowing pulse pressure. What is pulse pressure again? Do you guys remember that? It's the difference between your systolic and diastolic numbers. Okay, so let's say you take their blood pressure and it is 130/70. Okay, not great, but not bad. But then you take it again and it's 120/80. Okay, that's perfect, right? But it's more narrow than it was before. So we take it again and now it's 110/90. What's happening? It's getting more and more narrow. All right, that's an indication that something is pretty bad. Pretty bad. Or you may have what's called a herniation of the brain. So where is there for the brain to go when the brain starts to swell? Down. There's only one hole, and it's called the foramen magnum. So the only place it can go is down. And what did we say is the lowest part? Yeah, the medulla oblongata and the brainstem down here. So all this is going to crush the parts of the brain that literally control our heart, our respirations, and our vasomotor function. So that's why brain injuries are so deadly. Because the brain swells, it can only go one way, and it's down, and it's going to start squishing the parts of the brain that control everything. Everything that matters. All right, but head injuries, maybe they're not all severe. You have the scalp, and that's typically where we're going to get these soft tissue injuries or soft tissue injuries. The scalp is very vascular, so it may appear to be a nightmare, but in reality, it's not that big a deal. Okay, this guy's all cleaned up. You know, he's got taken care of. The bleeding has stopped. But when that was actively bleeding, that probably looked horrendous. All right, this is where people get tunnel vision. They kind of zoom in on one particular part of the body, and here they're probably going to zoom in on the head and ignore everything else. This guy might have like bilateral femoral fractures, but he has this laceration at the top of his head. What's more important? What's going to kill him? The fractures, yeah, absolutely. This probably not going to kill him. All right. Then we have deformities to the skull. Okay, so this requires extreme trauma, like a baseball bat. All right, falls from a significant height and landing on something like concrete. Okay, can cause a deformity. Most skull fractures are linear. All right, but then you may have a depression in the skull due to a blunt object, like I said, like a bat or something like that. Basilar skull fractures involve the floor of the cranium. We talked about that. We know that a sign of basilar skull fractures are battle signs. What's another indication that you have a brain injury? When we talk about underlying brain damage, if I were to look at the patient's eyes, one dilated, one constricted, that's a major sign that you have a brain injury. Now, that's the classical sign, but maybe they're both dilated or maybe they're both constricted, but another sign is that they don't react to light. They don't react to light. What does PERL stand for? PERRL. It's not. You missed an R. Round react to light. Pupils are equal, round, and reactive to light, but you hit the most important things. Pupils are equal, round, and reactive to light. Okay, so when we're shining our pen light in their eye, I expect to see constriction. When I pull the pen away, it needs to what? Dilate. So, yeah, it should go back to normal. So, here's something. If I shine a light in my right eye, what should my left eye do? It should do the exact same thing. So here you have people that, well, this just is the most common thing, and I don't like it. I'm not a big fan of this. They only shine the light in the eye once. So they do right eye, left eye, and call it a day. I do right eye, I'm looking in the right eye. I do left eye, I'm looking in the left eye. Then I do right eye, I'm looking in the left eye. And then I do left eye, and I'll look in the right eye. I do each eye twice, because I want to make sure that they are actually equal. That's how you assess equal. People ignore that for some reason. All right, here's an example of a skull fracture. Like we said, that they're typically linear. All right, this is a linear fracture. We can have brain injuries, like we were talking about just a second ago when we talked about the swelling and bleeding of the skull. All right, so let's say they have an aneurysm. All right, so they have a bleed in the brain. So maybe there's no trauma to the brain, but that blood is going to cause what? A buildup of pressure. That blood is going to cause a buildup of pressure because there's only so much room for the brain to go. So what happens when the brain continues to bleed and bleed and bleed? The pressure is going to build up, and it's going to cause everything we were talking about before, that herniation of the brain. But then you can have other injuries. Brain injuries caused by trauma are typically called TBIs, traumatic brain injuries. Unfortunately, during my service in the military, I've sustained quite a few of these getting blown up. They are not pleasant. All right. Traumatic brain injuries can occur from penetrating trauma, blunt trauma, or a secondary injury. They can be open or closed. All right. Sorry, there's something on my phone. Primary brain injury is a result of trauma to the brain that occurs at the time of insult. When we say insult, we're saying whatever the injury was, whether it was direct impact, acceleration, deceleration, or a penetrating wound. Do you guys remember coup, counter coup? I'm going to say clue. Coup, counter coup. So that acceleration, deceleration. So when we're driving, if we slam on the brakes, our body slams forward. What does our brain do? It's also going to slam forward. That's the coup. And then when we go back, okay, we have that immediate stopping. What is our brain going to do inside of our cranium? It's going to go back. That's the coup, counter coup. We have the front of the brain being injured. We have the back of the brain being injured. So that can be an acceleration, deceleration wound or insult. So this is our H's. Okay, you may hear H's and T's. This is our H's that we go through: hypoxemia, hycarbia, hyperglycemia, hyper and hypothermia, and then hypotension or hypertension. These are all T's that we have to go through. Hypoxemia is what? Not low blood pressure. Low, and then something with the blood. Low oxygen in the blood. Hypercarbia, what is that? Too much carbon dioxide in the blood. Nailed it. All right. What types of patients might be hypercarbic naturally? They have a condition. COPD, emphysema patients that are typically smokers. Nailed it. Hypoglycemia, hyperglycemia, hypothermia should be on here as well, and hypotension. All these things can make brain injuries worse. These are H's that we need to go through. This is just stuff that we should go through. All right, so with our secondary brain injuries, you may have patients that have seizures as a result of them. All right, contact ALS as soon as possible, because what can you do for a seizure as an EMT? Treat and transport, okay, and that's just oxygen if possible, and then moving them to transport, keeping them safe as possible as you move them. So we just talked about this brain herniation. So we have increased intracranial pressure, or ICP. Intracranial pressure, ICP. If we have that ICP building, the brain will start to herniate, and we can only herniate one way, and that's down. Herniation obliterates vital brainstem functions. Like we said, we have the medulla oblongata right there, all right, and it's just going to crush that part of the brain that controls all the vital things that we need: heart rate, vasofunction, respiratory function. Dilated or sluggish pupils on one side, okay, weakness or paralysis, severe alteration of consciousness, abnormal posturing. What are the two postures that we may see with brain herniation? Oh, yeah, it starts with D. Okay, decorticate and decerebrate. Decorticate, decerebrate. So towards the core for decorticate, and decerebrate, they kind of like, I can't, I had surgery on this wrist, but their hands will curl in and out. So they will do this number, and their feet will point outwards as well. They will curl out like that, and their head will go up and to the side. Decorticate, their feet will point inwards. All right. Cushing reflex, or Cushing's syndrome, all right, is increased systolic blood pressure and decreased heart rate. Okay? Increased systolic blood pressure and decreased heart rate. So their BP keeps going up and up and up and up, but the heart rate is going down. They may also have erratic or irregular breathing patterns. All right, so we're talking about types of head injuries, open versus closed. All right, it doesn't really matter. We're treating them both the same way. Like it says here, a closed or an open head injury does not signify a more severe brain injury. They're both, just automatically assume they're both bad. Okay, treat them both the same way. But if it's open, we have to put some type of dressing over it. Okay, because we want to prevent infection. If I have a patient that has a significant enough injury to the head that I have any type of deformity or depression, what is one of the first things I should do for them? C-collar. Yep. I'm going to do my HABCs, and then I'm going to put a C-collar on them. Or have my partner do it while I'm doing my HABCs. What's HABC stand for again? Hemorrhage, airway, breathing, circulation. Nailed it. All right. So types of brain injuries, brain injury from shearing or tearing or stretching. Okay, DAI, that's a diffuse axonal injury. Don't worry about this stuff. This is just additional information. You are not here to diagnose what type of brain injury they have. Okay, this is just extra info. Here's an example of a closed head injury. Why is this a closed head injury even though we see a break in the skin? Because the skull isn't fractured. The skull is not fractured, so it's still a closed head injury. But this guy has an open head injury because I can see his brain. All right, So here, a concussion is also a mild diffuse axonal injury. Again, we're not here to diagnose these things. A DAI is a brain injury in which scattered lesions occur over the widespread matter in the white matter tracts, as well as gray matter. I added this in. It's not on your slides, but I wrote that in there. But again, you're not here to diagnose a DAI, all right? Even paramedics, we're not here to diagnose that stuff. Concussions. Typically, they present with a headache. They may complain of, quote, seeing stars. You ever heard that? Who's played football in American football? Yeah. All right. You ever been knocked out before or had a bad enough bell rung that you're just kind of out of it for a little bit, saw stars, maybe a headache? You probably had a concussion at some point in your life. All right. You can have a contusion, which we know is a bruise, okay, to the brain itself. This can be accompanied with a concussion, or it could be separate. Here, the counter coup. I just mentioned this earlier. That bruising to the brain as it slams to the front of the skull, slams to the back of the skull, and acceleration, deceleration, MOI. Subdural hematoma is where? Below the dura mater. Okay, below the dura mater. This is a collection of blood between the dura mater and arachnoid. So if it's below the arachnoid, it's a subarachnoid bleed. Okay. So this is a subdural hematoma. So below the dura mater. Below the dura mater. So what did I say is going to happen when all this blood starts to build up a pressure? What do we call that pressure? It's not the insane clown posse, but it's ICP, intracranial pressure. Intracranial pressure, ICP. It's going to build up pressure, and eventually it's going to cause the brain to herniate. All right, subdural hematomas. So, these can be long-going bleeds. They can be going on for a very long time because what type of bleeds do they say it's associated with? What type of blood vessels? Venous. Okay, it can be a long, slow bleed. One of my patients that I had, this is like 2 years ago, a 55-year-old male. He was seen in the ER for a brain bleed. He was treated, seen, eventually sent home. He was discharged. One morning, he was not responding to his family, trying to wake him up. All right. He had woken up in the middle of the night, fallen, struck his head, managed to get back in the bed. But what do you think happened during that time frame? He started having another brain bleed. So they called 911, we got him to the hospital, and unfortunately he died there. He died in the ER. Nothing you could do for him. He'd already had a previous brain bleed, and one problem with brain bleeds is that if you've had one in the past, it's easier or you're more likely to sustain another one. The elderly, those with delayed clotting factors and alcoholics are at increased risks. So delayed clotting factors, or maybe they've had a stroke before. If a patient has had a stroke, what type of medication are they going to get put on? Blood thinners. And blood thinners make it more difficult to clot. So if you have a patient that has a head injury, what's one of the first questions you should ask? Are you on any blood thinners? If they can't answer, who do you ask? Family, friends, bystanders? If you're in their home, they can't answer. Friends and family don't know. What do you start doing? Looking for pills. Okay? Look in all the common places where we see medications and try to see if they're on any type of blood thinner, like Plavix, warfarin, Coumadin. Will somebody get that door? You guys don't mind? All right, more types of brain injuries. Epidural hematoma is where? Where's the bleeding? Above the dura mater. Excellent. Okay. So epidural hematomas. All right. So here it's above the dura. This is the bleeding that's happening. Subarachnoid, we talked about this, below the arachnoid. Okay, this is bleeding that occurs beneath the arachnoid membrane. We talked about it. A blunt force blow to the head is the most common cause of a rupture of the subarachnoid vessel. Okay, blunt force blow to the head. So maybe a baseball bat. It's my go-to when I talk about these type of trauma. It could be any type of blunt object. Even a fist could be enough to do it. If you're hit by, rest in power, but who just passed away? What famous boxer? You're monsters. His name's George Foreman, and he's a legend. Okay? If George Foreman was to smack you in the head, all right, the odds of you getting a subarachnoid hemorrhage probably pretty high. All right? So here is something to take into consideration. You may get a test question on this. A headache is often the quote worst headache, or you may see thunderclap headache. They may describe it as a thunderclap headache. You might see that on your national registry. They're going to say it might be like the patient describes pain as the worst they've ever had is a thunderclap headache. What type of brain injury do you suspect? Epidural, subdural, subarachnoid, etc., etc. Okay, subarachnoid hemorrhage are typically associated with the worst headache they've ever had. Nausea, vomiting, dizziness, pain and stiffness in the cervical area. Okay, throw them in a seat collar. Just FYI. Okay, if they're complaining of neck pain, just go ahead and do it just to be sure on the safe side. They may also have photophobia, so sensitivity to bright lights. When you're checking them for pearl, they may complain, they may yell at you, all right, but you're still going to check them. Seizures are possible with this type of brain injury. Here's an example of what it looks like with a subarachnoid hemorrhage. Not good. All right, talk about lacerations that can occur. Lacerations, we know, a break in the skin, all right, but here we're talking about the brain, all right? So maybe we have a laceration in the brain, which is a possibility. That shearing that we talked about earlier. Unresponses or altered level of consciousness, ALOC, okay, are a possible sign of a suggested head injury. Any evidence of a head injury during your DCAP BTLS. It says never assume that mental status changes in a trauma patient are due to drugs or alcohol intoxication. They could be drunk. They could be obviously drunk. You can arrive on scene. There could be beer bottles everywhere. They could have the smell of alcohol in their breath, but they could also have a head injury. Okay, so don't ever just get that tunnel vision and you're like, oh, he's just a drunk. That's why he's altered. Also, do your due diligence and do your assessments. Okay, we can ignore this. A fractured windshield, okay, also known as a spider web. Possible indication of or not possible, more probable head injury. Like something like this, all right, is a possibility. All right, this is a pretty severe depression. This should be an up and over injury, up and over the steering column. All right, so not only their head, but we're going to be worried about their upper extremities as well, anything else they may have hit. Just a bunch of photos. What did we call this before? Battle signs. All right, if we see bleeding from the ear, what are we going to check for? What's that test? Halo, which is indicating what? Cerebral spinal fluid. Why is that so important? If I have CSF in my blood, that means that the cranial vault, that the skull is fractured, and CSF is now pouring out of it, which is going to clue in, hey, this is probably worse than I thought. Other indication of basilar skull fractures, raccoon eyes. Okay, raccoon eyes. Okay, the normal assessments, holding C-spine. All right, this guy, I have to jet out of here pretty soon, but what type of injury do we see? What is our lower jaw called? Mandible. Okay, if I have this severe of an injury to the mandible, what am I concerned about? Fluid in the mouth. So HABCs, what am I concerned about? Airway. So what do I need to have on hand? Suction. Okay? Suction. Checking for APU, we know what that stands for. Doing the GCS, all right. Here's just the GCS more in depth. Again, we're holding the patient's head, we're holding C-spine, and palpating it. All right, checking for deformities, depressions, lacerations, or possible impaled objects. Checking for pearl. All right, checking for raccoon eyes, that bruising around the eyes, one or both. Checking for PMS. Why is that important when we suspect a head injury? Yeah, are they functioning right? Are they able to follow commands? Those are all important things that we need to assess. We're going to check the vitals every 5 minutes because they're unstable. High systolic blood pressure indicates increasing ICP. If they have low blood pressure, they may have bleed in another location, so never get that tunnel vision. Pulse, okay, the rate can indicate another source of bleeding, or if it is irregular. An irregular pulse rate might indicate that they have some swelling on the brain. Because what does it do? It manages all of that, okay? It manages your respiratory rate, your cardiac rate, and your vasotone. Respirations, rate, rhythm, and quality, okay? Because it can alter after a head injury, like I just mentioned. Checking for unequal pupils, fixed pupils, things that do not dilate or do not constrict to light. All right, so asking histories. What's a good history question you should ask of somebody, or probably a bystander, from somebody that's acting altered? Yeah, all those questions are great. When was the last time they were normal? Okay, are they always like this? Maybe they have a mental condition, and they just are like they are acting. Retrograde amnesia. Okay, so retrograde is they don't remember anything up to the incident. Anterograde is everything after the incident. So, car accident happens. I don't remember anything about it. Have no idea. Even though they were alert, quote unquote, talking to you, they just have no memory of it. Anterograde, they have no memory of after the event. Here's an example of unequal pupils. All right, and here's that decorticate posturing. And what's the other one? Decerebrate posturing. Okay, these are both bad. These indicate that the patient is dying. They are dying. Maintain C-spine, trait transport, okay, O2, keep them warm, get them on a backboard, control major bleeding, be prepared for seizures. There's nothing you can really do about it, so just transport as quickly and efficiently as possible. Do a handoff with ALS if possible. Reassess every 5 minutes. I'm kind of out of time, but there's not too much more content to this lecture. Do you guys have any questions up to this point?